We move on to the next case. That's a short case, cataract presentation. So the case will be presented by Dr. Manika Goyal from the School of Medical Sciences and Research, Sharda University. And the examiners are Dr. Manjunath, Professor and HOD, Government Medical College, Mysore, and Dr. A.V. Mallikarjun, Professor, KVJ Medical College, Sulia, who formerly worked as Professor in KMC Manipal and Yenapoya Medical College. So over to you, sir.
Good morning to the organizers at the outset. And I'm always happy to get connected with Kerala because for the last 30 years, I have been having friends from Kerala who have been postgraduates here, and now they are professors there and doing very well. And when Paul said hi, I was very happy because I've been going regularly as examiner to many of the colleges in Kerala because of Mubarak and others. And I always love Kerala and I'll always be liking to come there. And I was surprised when a postgraduate from UP called me and said she's going to present. I thought this was Kerala refresher course, and how did you get a chance to do it? That's a great show again, involving everybody all over, though it is a Kerala refresher course. Thank you very much and good morning to Dr. Manjunath.
Good morning, sir. Good morning, Dr. Mallikarjun, sir. Thank you very much. Definitely, it is a pleasure to be along with you as a senior colleague. And even I am also worked in Kerala, and I am happy to be part of the Kerala ISA refresher course. I was working in Kerala for some time, for nearly from 95 to 2000, I was working there. And many of them, especially Dr. Mubarak and everybody I know, they are our examination professional colleagues. And as I said, as you said, they are doing a fantastic job. And it is definitely good to know all the more postgraduates. There are many postgraduates watching this video, and definitely we're going to have a very good discussion follows. Thank you, Dr. Mallikarjun, and I'll go ahead with the presentation. I think Dr. Mallikarjun, sir.
Yeah, welcome, Manika. You can start your presentation.
Good morning, all. I am Dr. Manika Goyal from School of Medical Sciences and Research, and I am going to present a short case of cataract. My patient Raman Kumar, a 67-year-old male, Hindu by religion and farmer by occupation from Dankor, UP, came with chief complaints of diminution of vision in both eyes since 8 months, with right more than left. Patient was apparently all right 8 months ago when he began to develop diminution of vision in both the eyes, which was more in right eye. It was insidious in onset and gradually progressed to current state. Diminution of vision was same for both near and distant vision, and it was not associated with pain, redness, watering, discharge, headache, double vision, colored halos, or frequent changes of glasses. The patient has been using glasses for 20 years for myopia until 40 years of age, and then he changed to glasses for presbyopia type. No history of ocular surgery, trauma, or use of steroid eye drops was present. My patient is a known case of hypertension since 8 years on tablet telmisartan for 40 mg. There is no history of diabetes mellitus, asthma, ischemic heart disease, or tuberculosis. Family history was insignificant, as well as surgical history was insignificant. The patient takes a mixed diet, predominantly vegetarian, with normal appetite and regular bowel and bladder movement. Patient is a tobacco chewer for 20 years and doesn't consume alcohol.
Okay, so you have given the history of this patient who is complaining of diminution of vision.
Yes, sir.
How are you associated with the ophthalmology OT? How often you go to the ophthalmo OT?
Sir, mostly they perform the surgeries under their arena only. It is only for specific conditions when we need to give GA in pediatric or psychiatric patients or patients who are apprehensive, or in cases when patients present with hypertension or bradycardia during intraoperative periods. That is when we are called for.
Most of the time it is the ophthalmologists are managing their own cases unless they require a general anesthesia for this pediatric or elderly patient, apprehensive, psychiatric patients, and some trauma where you are called upon to give anesthesia. So it is not an environment where you regularly give anesthesia. Plus, why is it that ophthalmic surgeries are done under local anesthesia most of the time than under general anesthesia? What are the advantages? What are the disadvantages of this?
So most of the patients they so most of the patients are geriatric patients with many comorbidities. So they want to, so the effects of the general anesthesia can be allayed by using
Is
regional
that the
blocks.
reason why they do under local?
So they can provide well akinesia and well analgesia and akinesia can be well done with the blocks which they
Yeah, the
and
blocks
topical
are
anesthesia.
it is not because the patients are elderly, not because the patients have comorbidity that these patients land up with the local anesthesia. Because local anesthesia with 1-2 injections can provide good analgesia, akinesia, what is required for them. Even a very sick patient with multiple comorbidities can be taken up under local anesthesia. That is the reason why most of you said the patient has come with the loss of vision. What are the common causes for this diminution or loss of vision? You have to know about.
So they can be either congenital or acquired. So in congenital causes, we can have it can be because of syndromes like Down syndrome or congenital rubella syndrome and phenylketonuria. And in acquired causes, it can be due to cataract, due to diabetes mellitus, cataract due to diabetes mellitus, then galactosemia, then it can be due to raised ICP. There it will be because of sudden there they will present with sudden loss of vision, then due to trauma or infections.
Okay, what about
sir, 1 minute.
Yeah.
Sir, Monica, because
Yes,
your
yes.
patient is a 67-year-old patient with hypertension. So regarding this, so patient is having a diminution of vision. Any other history relating to your hypertension? So because could the hypertension can cause the diminution of vision?
So
Could it be a cause for your diminution of vision? Hypertension.
Stroke can cause.
No, long-standing hypertension. So you have to think of changes in the long-standing hypertension in the retina, in the retinal vessels.
Yes, sir. Hypertension can have end organ damage, including retinopathy.
Okay, that's the one thing you have to rule out. And what are the other things you will rule out in the history as well as history is concerned? Because it's a hypertension patient and a old age patient. Any other causes regarding the just whether this is a region, this is an old age patient, is a natural history of the patient, so that you will going to have that diminution of vision. Any other causes pertaining to the diminution of vision as far as the old age is concerned? You have to look for the history wise. Patient is a myopic for nearly 20 years, right?
Yes.
Yeah. Any other myopic changes you can think of? No, because of their long-standing myopia, patient might have gone for changes. A lot of changes are there in the retina. That was one of the causes.
There will be increase in the axial length, so there will be thinning of the retina. So the tears in the retina can be because of myopia.
Okay. So history of myopia, is it relevant in this patient as far as your anesthetic management is concerned?
Yes, so for many blocks, we need to have the axial length. The axial length should be known, and it should be at least within 25 millimeters. If it is more than 25 millimeters, then chances of globe injury are high.
Okay. That's one thing is, so as far as the myopia is concerned, you should be very careful. And during a performance of your block, you should be very careful about the globe perforation and the axial length. Okay, one thing. And second thing is, because of this patient is a hypertensive patient, and whether it is well controlled or not, so the past history of the hospitalization, you should inquire. So past history of hospitalization, past history of any CVA relating to the hypertension episodes, hypertensive crisis, that it should be included. I think you're going to, I think you're not inquired about the past history of hospitalization.
Sir, surgical history, and there was no any ocular trauma or any such hospitalization history, sir.
Okay. Patient is a diabetic?
No, sir.
Okay. Any other history suggestive of vascular malformations, headache, persistent headache, vascular malformations?
So
okay. Could it be a cause for this diminution of vision? Any other vascular malformations?
Yes, sir. There are vascular malformations in the retina which can cause diminution of vision. There can be so black spots can be seen as the patient will complain of.
Because the patient is old age, you should ask about the history of atherosclerosis, ischemic heart disease. So you should inquire about the history of heart disease. Is it important? Yes. Yeah. Is it important as far as your diminution of vision is concerned? Ischemic heart disease?
So they are more prone to So they are more prone to hypotension, so that can cause sudden loss of vision by decrease in the perfusion.
Okay. So history wise, you have come general history wise. What is your diagnosis as far as the history is concerned? You have taken history, and what is your opinion regarding the history?
So that the patient is a 67-year-old elderly patient and a known case of hypertension presenting with diminution of vision. And the cause has to be found out. That is most likely due to old age.
Okay.
Cataract.
Sir, Mallikarjun sir, carry.
Yeah, you said old age. Can you classify the geriatric patient?
Yes, sir. Sir, elderly patients are individuals with age more than 65 years. They from 65 to 75 years, they are young old. From 75 to 85 year old, they are medium old, and more than 85 years, they are oldest old.
Why are you worried about a geriatric patient? What are the common medical conditions which you come across in your day-to-day practice?
So there are several comorbidities, like in respiratory, they usually have COPD. Then in CVS, they are known cases of ischemic heart disease, hypertension, or they might have pacemakers or this thing. Then in CVS, in cerebrovascular, they might be candidates of stroke. They might have a history of stroke or cerebrovascular disease. Then in endocrine, they might have diabetes mellitus, thyroid disorders, which and in renal they can have CKD. So these all have to be taken into consideration when we take up such a patient.
So whenever you come across a geriatric patient aged more than 65 years, you look for all these conditions. And when you said history of hypertension, as Dr. Manjunath sir said, you have to look for end organ damage in these patients. In your history, you never mentioned about, you just said the patient is a known hypertensive. Am I right?
Yes,
sir.
You should always look for any end organ damage, that is either the respiratory effort, the effort tolerance should be mentioned. Of course, this is a short case. I don't know, exams you'll have just about half an hour. Will not allow you to present the whole case. We will just ask you what are the positive findings so that we can discuss more about the anesthetic. Okay, what are the common surgeries you come across in this geriatric patient other than cataract? One is cataract, of course. Very often you come with geriatric patients.
It's long bone fractures, then like hip fracture, then TURP, hernia. So these are the common.
Okay, what are the anesthetic implications of a geriatric patient? We'll just enumerate. We'll not go into the discussion.
Yes, sir. Yes, Mallikarjun sir, you said this is a short case, and usually we never ask the posterior to present this case straight away. As you said, we will ask for the diagnosis and positive points and straight away. But because we are given a long case, we given a 35 to 45 minutes, you can go for the test for just, sir. Yeah, sir. Okay, yes, sir said. So what are the complications of geriatric? Yeah, go ahead with Monica.
So there are many physiological changes, like in CVS, the arteries stiffen.
What are the changes? What are the implications you want telling? What happens to the respiratory system, cardiovascular system, their skeletal system, and their anesthetic implications?
Sir, in CVS, there is impaired baroreceptor activity, due to which they are more prone to hypotension during intraoperative and in the perioperative period. Then they have ventricular hypertrophy, so they are at an increased risk of diastolic dysfunction or fluid overload at any time in the perioperative period. Sir, in the respiratory system, sir, the arteries are stiffened, so therefore there are chances of hypertension. And sir, in the respiratory system, they have reduced ventilatory response to hypoxia and hypercarbia. Then they have reduced airway reflexes. Therefore, there are increased chances of aspiration. The parenchymal changes are there. So the ventilation perfusion mismatch is also
there. What happens to the residual volume?
Sir?
What happens to the residual volume?
The residual volume increases and the closing.
Decrease FRC?
Yeah. Functional residual capacity.
Sir, FRC decreases.
Yeah, that is very, very important. Yes. FRC is very important as far as the respiratory system is concerned. So what is meant by FRC? What is the relationship of FRC with the closing capacity?
Sir, FRC is the volume of air which remains in the lung after normal expiration. And
Okay.
sir, closing capacity is expiratory reserve volume. It is a capacity, that means it is a combination of two volumes, that is residual volume and expiratory reserve volume. Sir, it is the and the closing volume. Sir, it is the capacity. It is the volume of volume at which
No,
the
what is yeah, 1 minute. My our question is, what is the FRC and closing capacity? What is the relationship between the FRC and closing capacity?
Sir,
And why we are worried about that in old age?
So because closing capacity increases and FRC decreases, therefore the ratio which should be more than 1, it reverses, and there are chances of small airway closure at normal tidal volumes also in old age.
What is your worried? Why are you worried about that?
They are at increased risk of desaturation and atelectasis.
Yes, yes.
So pre-oxygenation in these patients is very important, and shorter duration of laryngoscopy and intubation will always prevent hypoxia, especially if they are compromised patients. Okay, go ahead. What happens to their spinal and epidural?
So the epidural space is reduced. The spinal and epidural space is reduced because of the calcification of the ligaments, and therefore there are chances of higher levels of the neuraxial block.
What is the epidural dosage of your local anesthetics? It keeps on reducing with age.
Decreasing with age.
Okay.
Then so the number of neurons.
Central nervous system, Manika. Yes. How will they react when you go to see them? Okay, you're gone for this patient only. This patient was requesting general anesthesia for some reason. So when you go see him, how do you go about talking to him? What problems you get when you are talking to these patients?
So they are hard of hearing. They usually have difficulty in understanding language. Issues are there. There can be sluggishness while speaking. Then they might be so depressed, or they might be such. They might be anxious, and they might not be able to understand the procedure they are about to undergo.
What about the hard of hearing? Patient might have a hard of hearing. Patient might have a decreased cognitive functions, may be decreased.
Yes.
In these patients. Okay.
Cognitive function is very important in these patients. So you should look for all those things. Yes. What happens to the renal function and the liver?
So the renal function, the creatinine clearance decreases, and therefore there can be decreased clearance of the GFR and renal blood flow. It decreases. Therefore, there can be decreased renal clearance of various drugs. And similarly for hepatic, so the hepatic blood flow decreases, and the function of P450 enzymes also decreases. So hepatic clearance of drugs is reduced. So the total body water, it decreases, and the body fat increases. So the volume of distribution for lipophilic drugs, it increases, while for hydrophilic drugs, it decreases.
So what will you do when the volume of distribution is increased? What does it matter to you?
So,
how will
sir,
you use this during your anesthetic management?
So, sir, drugs like benzodiazepines, they are more sensitive to benzodiazepines, and there can be prolonged actions of such drugs.
Yeah.
No, what is the dosages of the drugs? Dosages.
So the doses are usually reduced.
So you have to be given titrated dosage. Okay. So sleeping dosage or induction agents and all the drugs should be decreased. So you should not go for a regular dosage.
Regular.
Okay.
What about muscle relaxant in these patients with large volume of distribution?
So the plasma cholinesterase activity decreases. So therefore, the depolarizing agents, they can have a prolonged action, and the non-depolarizing agents, they have.
Yeah, what about the neuromuscular receptors, neuromuscular junction, changes in the neuromuscular junction? Also, we have to tell about that. Changes in the neuromuscular junction, receptor level, okay, volume distribution, everything will be counted here. So that decreased dosage of the drugs, the maintenance dose should be decreased. Okay.
Okay, go ahead with your
general physical examination, sir.
The patient was examined under adequate light. My patient was well oriented to time, place, and person with height 153 centimeter, weight 65 kgs, and a BMI calculated to be 27.7 kgs per meter square. The vitals were grossly normal with temperature 98°F, pulse rate 82 beats per minute, regular rhythm with normal tension, volume, and character of vessel. All the peripheral pulses were palpable. Blood pressure was 140 by 80 millimeters of mercury measured in right arm in sitting position. Respiratory rate was 16 per minute and no pallor, icterus, cyanosis, clubbing, lymphedema, lymphadenopathy or edema was noted. Airway examination was normal with mouth opening 3.5 centimeter, thyromental distance 7 centimeter, upper lip bite test grade 1. Oral cavity had absent anterior upper incisors and loose right lower premolar. No dentures were present and Mallam putty grade was 2. Neck movement was adequate with more than 90 degrees.
Okay, when you check the blood pressure, the BP was 200 by 110 on the preoperative day. You said the patient is on telmisartan 40 mg.
Yes, sir.
What you are going to do now?
Sir, the acceptable level of BP, sir, the BP should be should be less than 180 by 110 millimeters of mercury. So 200 by 110 millimeters of mercury. Here we will have to find out the cause that the patient might be anxious or.
When you go see the patient, the BP is so much. When you check back the records, the blood pressure is 150 by 80, 150 by 90. What do you think it could be because of?
So it might be because of anxiety.
Yeah, white coat hypertension.
White
we are not discussing hypertension because somebody else is also presenting. But since this is a patient with hypertension, you should always think of anxiety and white coat hypertension. What is pulse pressure?
So pulse pressure is the difference. Is the difference between systolic and the diastolic blood pressure.
Suppose
what happens in this patient? What happens in these patients who are the old age patients?
So the pulse pressure increases because of the stiffening of the vessel.
Okay. So do you want
systolic pressure increases and diastolic decreases.
200 by 90. You want to treat this hypertension further?
So first I would like to counsel the patient. And if still not, then I can give sir small doses of benzodiazepine.
Okay, my question is, if you want to add any antihypertensive to this higher BP, don't try to reduce the systolic pressure. Why is it that diastolic pressure is more important for you?
Sir, that is because diastole is the time when the coronaries get the blood supply. So, the myocardial perfusion can.
Monica, one more thing. Just yes, sir has said the blood pressure is about 200 by 120. So, because white coating effect and you are given a small dose of midazolam, it has decreased. And this physician says that I will going to manage this case. Go ahead with the surgery. What you will going to do it? What is the implications of this increased blood pressure? Why are you worried about this increase in blood pressure as far as your cataract surgery is concerned?
Sir, increase in blood pressure is also associated with increase in intraocular pressure. Yes, and so, sir, there will be, so there can be a hemorrhage, or there can be,
one more thing. What is meant by ocular perfusion pressure? What do you mean by ocular perfusion pressure?
Sir, ocular perfusion pressure is MAP minus intraocular pressure. That is mean arterial pressure minus intraocular pressure, which is the pressure at which the retina and the optic nerve are they receive their blood supply. So, sir, if there is any
worried about that? Are you worried about that?
Yes, sir. If there is any increase in the intraocular pressure, then perfusion pressure will decrease and can cause
what is the normal intraocular pressure? What is the normal intraocular pressure?
So 16 plus minus 5 millimeters of mercury. And if it is more than 25 millimeters of mercury, we can label it as intraocular.
Are you worried about that?
Increased.
When sir, this situation, sir has said, so you are worried about the ocular perfusion pressure also, you have to be worried, and you have to postpone the surgery till the optimization of the blood pressure is done. I think, sir, okay, sir.
Mallikarjun, sir. Very good. She was right. Can you tell something more about IOP? You said the normal pressure is 16 plus minus 5. So the normal pressure is about 10 to 20. What are the other effects of increased ICP? What happens if you are doing a surgery in a raised intraocular pressure?
So there can be a protrusion of the orbital contents if there is an open eye injury, or whenever there is a corneal transplant, full thickness corneal transplant, then the intraocular pressure is in direct contact with the atmospheric pressure. So there can be evaporation of the orbital contents.
Okay, then once you said about intraocular pressure, you have to know what the anesthetic induction agents, your narcotics, your inhalational agents, which have an effect on the IOP. Which would you like to use, which you would like to avoid to have any great changes? You don't mind reducing the IOP, but you don't want the IOP to go up. So what are these drugs which can affect the IOP?
Sir, all the inhalational agents, they decrease intraocular pressure.
No, sir, sir, as to which are the drugs which you can avoid?
Which can avoid.
Yeah.
Sir, amongst the inhalational agents, we must avoid halothane.
No, what happens with inhalation anesthetic agent, especially as far as the IOP is concerned? Is it safe to use inhalation anesthetic agents or not? Inhalation anesthetic agents, generally what they do, whether it decreases the IOP or increases the IOP?
It decreases IOP.
Oh yeah, what are the drugs which you can avoid? Any other drugs? See,
Sir, we should avoid succinylcholine and
yes, succinylcholine will be avoided. Any other drugs?
ketamine, sir, although some new studies say that it doesn't.
Yes.
Okay, but for exams, you can always say avoid ketamine.
Yes.
What about the muscle relaxants? Anything other than suxamethonium, non-depolarizers?
The pancuronium should be avoided because it is long-acting and histamine releasing.
Okay, so you should always know that IOP is an important factor during eye surgeries, especially when what are the anesthesia techniques which can result in raised IOP other than the drugs?
So
your procedure, you are doing your induction, you are doing everything though. What are the precautions you want to take to decrease the IOP, starting from the mask ventilation?
Yes. So the external pressure, which can be because of the mask, which is covering the eye, it can increase the IOP. Then during laryngoscopy, if the duration is
pressure, you should say pressure on the eyeball should be avoided. So you have to unnecessary undue pressure. The hold in the mask should be perfect. Otherwise, you are going to have undue pressure on the eyeballs. Eyeballs should be protected during the induction, during your mask ventilation. You should be very careful as far as the eye is concerned. Okay, one thing. Okay.
Then, sir, during laryngoscopy, the duration should be smooth and short duration, less than 15 seconds. Sir, preferably video laryngoscopy can be used. Then, sir, at the time of extubation.
What you said? What you said? Video laryngoscopy
should be preferred.
Video laryngoscopy.
Sir, if we have a choice between direct and video laryngoscopy, then we must.
So you want to avoid the laryngoscopy?
Yes, sir.
By the laryngoscope. Okay. But most of the time, it is not an easier technique compared to your laryngoscopy. Shorten the duration of your laryngoscopy. Do a quick, smooth intubation. Use some drugs which can prevent.
Intubation response. Attenuation of the intubation response is very, very important. Yes. Okay. So you attenuate things. Yeah, you have to attenuate because this is a hypertension patient. You should take care that the hypertension crisis should not happen, and you have to attenuate this with some drugs. What are the drugs you can attenuate the hypertension intubation reaction in these patients?
So we can use IV preservative-free lignocaine in the doses of 1 to 1.5 mg per kg 45 seconds before the laryngoscopy. Then we can also use adrenergic inhibitors like labetalol, or we can use sodium nitroprusside or nitroglycerin. But mostly lignocaine does a good job.
3 ml of 2% lignocaine 90 seconds before your laryngoscopy has to be given IV. These days we also use fentanyl 1 to 2 micrograms about 30 seconds to 45 seconds before. Yes, we have dexmedetomidine. So many drugs are there, and you should make sure that when you are doing a procedure like this in a hypertensive patient, you don't want the IOP to go up. You see to it that you do these things very carefully. Okay?
Bottom line is gentle laryngoscopy. That is very, very important.
Yeah. Gentle laryngoscopy, short duration, well lubricated tube.
Yes, sir.
Yeah, okay. Go ahead.
Ocular examination. The head posture was straight and erect. Both the sides of the face were symmetrical. Ocular symmetry was symmetrical. On bedside visual acuity, projection of.
Skip this.
Yeah. Are you routinely examining this eye examinations? So usually this anesthesia part, especially our postage, they will be given so the diagnosis will be given. Only thing is, for the sake of the completion, you have to examine. Especially for the short procedure, you may not require. And as far as you are not an ophthalmologist, you are an anesthetist. So you examining the patient as an anesthetic point of view and ophthalmic anesthetic implications of ophthalmology you have to know. Okay, Manika? Sir, yes, yeah, that's why sir has said skip this slide.
Any positive findings in the CNS?
No, sir.
CVS?
No, sir. So
okay.
No systemic positive.
Sir, one more question, sir. One more. As far as the CNS is concerned, any relevant history which is relevant to the cataract surgeries? CNS examinations.
Sir, in the meningeal irritation sign,
what are the signs of vertebrobasilar insufficiency? Is it important, vertebrobasilar insufficiency in these patients? No, vertebrobasilar insufficiency. If the patient is having suddenly dimness of vision, sudden loss of vision after getting up from a sleep, is it important?
Not right.
No, because these patients may go in for sudden loss of vision in these patients also. So because of the atherosclerosis and because of the luminal narrowing of the vertebral artery, these patients, so you can expect some amount of problem in the vertebral, problem in the eye also. Okay, that you should inquire. Okay.
So
okay, summarize. Sorry, sir. Sorry.
No. Go ahead, sir.
Okay, sir. Mallikarjun, sir, go ahead.
Yeah. So you have a patient who's posted for cataract. What are the choice of anesthesia you have in this patient?
Sir, before that, sir, Mallikarjun, sir.
Yeah.
Sir, would you like to go for any investigations? Because before that, sir,
yeah. When I ask you what anesthesia, you are supposed to tell the
yes, okay,
investigation.
Sir, okay.
What investigations you want? Routine.
Sir, routinely for ASA 1 and 2 patients, special investigations might not be required, but for
Monica, one more thing before going on to the one investigation parts. This is a patient with a 67-year-old male, hypertension for 8 years with antihypertensive medications, presented you for a cataract surgery, right? This is the case scenario you are going to give in it. So for what is the next, how will you going to prepare this? How will you going to do it? So when you are going to call, whether you are going to have an array of investigations, okay? So blood routine investigation and special investigation like that, or is there any caveat? What is the pre-anesthetic evaluation during the pre-anesthetic evaluation? What is the recent guidelines saying that regarding the pre-operative investigations in these patients?
So recent guidelines say that for ASA 1 and 2, no investigations, no routine investigations are required. But
okay.
If the patient has any medical illness, then investigations appropriate to the medical illness may be taken up. Like for
one thing is, this is a very low risk surgery. The cataract surgeries are considered as a low risk surgery, but the patient is a high risk patient. Two things contrast. It's a low risk surgery and the patient is a high risk patient. So there are two schools of thought regarding the pre-anesthetic evaluation. One says that there may not be any requirement of investigation and they can go ahead with the regional blocks. The second school of thought say that you have to go for a full investigations. So starting from everything, patient should be in a optimal medical conditions during the surgery. Okay, there are two schools of thoughts, but as far as our guidelines is concerned, as far as recent, because of the patient safety and medical legal purpose. So just take it this medical legal purpose. As far as patient safety is concerned, you have to go ahead for a normal investigation. You have to go for routine investigations, right? You have to go for routine investigation, and patient should be prepared as an optimal condition at the time of surgery. Okay, sir, Mallikarjun, sir.
Yeah, go ahead with your investigations now. You always in the exams when they ask what investigations you want to do, You can always say that I would like to do HbTC, TCSR, urine albumin, sugar, micro, blood urea, creatine, blood sugar, chest X-ray, ECG. These are the routine things what we do. And for every case, you can just go on repeating this. No examiner will say no for it. Then what are the special investigations you want to do? Of course, you have a thyroid patient, you have a cardiac patients, then you can add on. These are the routine investigations which we do in almost every patient has. Manjunath sir said that because of our constraints, medical legal problems, we would like to have these basic investigations done in all the patients. Okay, when you did all these investigations, they are within normal limits. Now, how about you go about preparing this patient for an anesthesia? I am not still saying whether it's general or regional, but what will you do on the previous day? All investigations are within normal limit. The BP is under control. So what you're going to do on the previous night?
Sir, I would like to prescribe an anxiolytic for the patient, and first I will take an informed written consent. I will give the NPO orders, the 8 hours for solid and 6 hours for semi-solid and 2 hours for clear liquids. Then I would like to ask the patient to omit the morning dose of ARB. Sir, it is an angiotensin receptor blocker, so I would like to skip the morning dose of.
There are two things. What is actually said about antihypertensive drugs, and which are the drugs you want to skip and why? In general, what you do with your antihypertensive drugs in a hypertensive patient before surgery?
Sir, in general, ACE inhibitors and ARBs are the ones which we skip before the surgery, on the day of the surgery, on the morning of surgery, and sir, rest all are continued.
Okay, why you want to, is it always that you want to skip your AC inhibitors? Are there two schools of thought?
Yes, there are two schools of thought, because one school says that it might cause it might cause hypertension intraoperatively, and the other might say that it causes catecholamine resistant hypotension.
So what is your school? In your hospital, what your consultants follow, what your teachers tell you?
Sir, for small doses we continue, and for minor surgeries we generally continue.
One more thing, surgeon says that this is a small surgery, I don't require any investigation, I don't require any. So only thing is you just come and stay behind me and say near the patient, I will going to go ahead. What your opinion on this? Usually this is thing happening, especially cataract surgeries. The surgeons, they will going to give the block and they will going to do the surgeries. They said, ask the patient to take full breakfast and come for the surgery. Okay, they will going to say that you have your food and come for the surgery because you are going to have a fainting attack. So you have to have a full stomach. So take full breakfast and you take all the medications, and there is no, they will going to advise the patient. This is the commonest things happening in our institutions, because we as anesthetists will go as a standby anesthesia. That is called standby. So what your take on this? Would you like to go for a, would you like to go for a
free surgeon to keep the patient's NPO, no matter so because the patients are high risk, no matter the surgery is low risk, but then the patients are high risk and might require airway handling or sedation also at any time. So sir, the entire pre-operative assessment should be thorough with sir, the adequate NPO should be maintained.
Okay, you are called upon suddenly in the theater. Our patient is not cooperating, the block has failed. Please come and give sedation or anesthesia. What will you do?
Yeah, this is a typical situation, sir has said. This is a typical situation where we are calling for, we are called, especially as a ophthalmologist, we're going to call you like this.
Sir, I will check for the vitals and for the history. I will also ask for the history of the patient, if the patient has any comorbidities, and sir, accordingly, if allowable, then I will give a benzodiazepine. Sir.
Make sure that the patient is fasting. Make sure that the patient's vitals are normal. Get a quick history about the patient. If you have any doubt, you say that I am not very confident going ahead with this case because the patient has not followed strict NP orders. As they said, they usually come with a breakfast and then are posted. So always see, most of the situations we are never called in, unlike this. Suddenly, okay, this is one situation where you are asked to come and give general anesthesia. There is another situation they call you. Patient is having bradycardia. What are the causes? We are running short. We have just another 4 minutes. Sir, we'll try to finish it in
Yes,
time.
sir. Yes, sir. So,
what do you think the bradycardia could be and how do you prevent it?
So bradycardia may be because of the oculocardiac reflex intraoperatively, or maybe because the patient was already on a beta blocker and it got exaggerated.
Okay, I say this is an oculocardiac reflex. What is it? And how do you prevent it? How do you manage it?
So oculocardiac reflex is trigeminovagal reflex, which was introduced by Ashnell and Dagnini. And sir, it is usually due to traction of the extraocular muscles, or even the extraocular of the intraorbital contents, like the globe or the periosteum. Also, it occurs most commonly in pediatric patients during strabismus surgery, mostly with the traction of the medial rectus.
what about in old age? Old age, does it not occur in old age patients?
Sir, it occurs because mostly now cases are, sir, it can occur whenever there is a traction
whenever
on.
There is any pressure on the eyeball, or even during giving a local anesthetic agent, sir.
Yes,
the local anesthetic agent also they will going to cause oculocardiac reflex. You should be very careful of.
Yes.
So what are the symptoms of oculocardiac reflex?
Sir?
What are the symptoms?
Sir, it presents with bradycardia, arrhythmias, or junctional rhythms, or asystole.
I said
along with
the findings. How do the patient present? How will the patient react to a bradycardia? Nausea, vomiting?
Nausea, vomiting, simple.
Right? That is the symptoms. These are the findings. How do you treat it?
So first we will ask for to stop the manipulation of the globe. Then we will check for appropriate ventilation and oxygenation, and deepen the plane if required.
No, you are given. Say this patient has given a regional block. Usually under regional block, the patient will be undergoing surgery. So manipulation is stopped. You give atropine.
Atropine.
What is the dose? Yeah.
Atropine in 7 mics per kg increments.
Okay. Will repeated oculocardiac reflex happen?
So it generally doesn't happen because of the fatigue of the reflex arc of the cardio inhibitories.
Remember that the first attack is the worst, then subsequently the brady is much less. Yes. But this is one situation where you are called upon to tackle the patient. Other situations where you are called upon in a ophthalmic OTs, the patient is restless, patient is having hypertension, patient is having hypotension, please come and do something. And one last few question is, when you give general anesthesia, you want to keep the patient spontaneous or you want to ventilate the patient?
So I would like to ventilate the patient.
Endotracheal tube, or you want to use a LMA? Why? 2 questions you have to answer.
Sir, I would like to use an LMA because it will prevent the effects of laryngoscopy and endotracheal intubation and extubation. So the increase in IOP will be avoided. Yeah. Then, sir, so the other question was.
So LMA, would you like to use LMA in this patient?
LMA, sir. I would like to use LMA because sir, the increase in IOP will be avoided.
The other question is, you want to keep the patient spontaneous or ventilate?
Sir, I would like to ventilate the patient because sir, if I keep the patient spontaneous, then the chances of increase in IOP are higher, sir. Because of
carbon dioxide retention and oxygen. If you keep the patient spontaneous, if the patient hypoventilates, there will be accumulation of carbon dioxide. There will be increase in your pressures. Okay. Thank you, sir. Your last question for her.
Yeah. Monica, what is the regional, just enumerate the regional blocks which you have, we can give for these patients. What are the enumerate the blocks?
So retrobulbar block, peribulbar block, subtenon block. So these are the 3 regional blocks which we can give.
Have you given any blocks?
No, sir.
What are the recent advances? Recently, can you give? Recently?
So we can give ultrasound guided. We can
Yes, sir.
give these blocks ultrasound guided, so they are
Okay.
more safer, and the needle trajectory can be seen. It is just that special probes are required.
Why
for
special probes are required?
So because
Nowadays,
so there are
normal
two
probes,
index.
yeah.
So there are so there are two index, that is
Yes.
thermal index and some mechanical index. So so the thermal index is the level the
No,
amount
the tissue temperature will be raised because of normal. If you use a normal transducer, the tissue temperature will be raised.
temperature will increase.
Yeah,
Yes.
that is the one
It has
thing.
a short duration of less than 90 seconds.
Yes, very good. So less than 90 seconds. So you have to use a different,
Probe.
yeah,
Probe.
probe for this one. Okay, one thing. What are the complications as far as your normal these things are concerned? Regional blocks. Complications of regional blocks. That's a pet question for the examiners.
So for retrobulbar block, most commonly there is retroorbital hemorrhage. There can be ocular perforation. Then, so because of this, then there can be central retinal artery occlusion. So for the peribulbar block,
one more question I'm going to ask. The patient has given a retrobulbar block. Okay, they use a local anesthetic agent. They given a retrobulbar block. Patient has stopped breathing. Okay, it is not responding. What is your take on this? How will you going to manage? What is your diagnosis? Patient has stopped respiration. He has stopped respiration and he is not responding to your commands. The moment you are given the local anesthetic agent, he has stopped breathing and he is not he is lost his consciousness. What is your problem? What is the problem? What might have caused this?
so due to brainstem. So due to
the injected local anesthetic can enter into the enter into the subarachnoid block. So it can enter through the optic nerve sheath. That is the one commonest dreaded complications. Okay, so patient can go for respiratory arrest immediately. So you have to be very careful. One thing. Second thing, suddenly patient may have going for systemic toxicity because of the intra-arterial injection. Conversions may also be happen. So you should be very careful as far as to the dreaded complication is concerned. Okay. Sir, Mallikarjun sir.
Thank you, Manika. You have done a good job. I think you are well prepared for your exams. All the best. Thanks to the ISA Kerala. Thanks to Venkatagiri et al. And thank you very much, Manjunath sir.
Thank you, sir. Thank you,
Thank you.
Thank you, Monica. Thank you. You have done well. Good luck for your examination.